So the first case is a 78-year-old gentleman had symptomatic severe aortic stenosis. He had a new lung mass that had a biopsy-proven squamous cell carcinoma. Pulmonary and oncology that's seeing him said he has a good 1-year prognosis, but go ahead and proceed with taking care of his valve so then we can do chemoradiation, shrink that mass, and take him to surgery. So in terms of medical and surgical history, he has COPD, not on any home oxygen. He's had a prior CABG. His SDS is low, but we're proceeding with TAVR just because of the urgency of him needing to get that surgical resection of his mass. On echo, he meets the gradients in terms of it being severe, and on cath, he had all 3 grafts that were patent. So this is just to show his pre-cath echo showing severe aortic valve stenosis. Since I put this together yesterday, I borrowed the 3 Mencier report just to show in terms of CT sizing. I usually do my own CT sizing, and I size based on mean diameter and not so much on area or perimeter. And we predominantly do use SAPIEN 3 at our institution. So based on the CT measurements, we looked at the coronary heights, SDJ, everything was pretty straightforward. We decided to go with the 23 valve. We had moved forward and we're doing conscious sedation. We do have a new surgeon starting with us, and until he gets to the comfort level, we've sadly been going back to now reintubating the patient and putting a TE probe down, which in this case saved us. So get our implant angle, we put in a 26 SAPIEN 3 valve. Everything goes pretty straightforward, no surprises at this point. Okay, so then we look at our post-deployment echo. There's just trivial regurgitation, nothing surprising. The catheter and wire come out and the color Doppler come off, and then we see this. So just to give you a little background in that, we always have a tendency to say, give heparin. We hear the anesthesiologist confirm that they've heard and that they've given heparin. The anesthesiologist confirmed that they heard that heparin was given. And right before I usually take the valve and the device, I have a tendency to ask for what the ACT is. At that point, the tech that usually checks our ACT said, well, heparin wasn't given. Keep in mind, at this point, we've already done the pre-ballooning. We hadn't taken the device in the body as yet. So we go ahead and give the heparin bolus. We wait about a minute or 2, then we go ahead with the device because now we've given a large bolus of heparin. We deployed the device. The sheath was in already. We suctioned, we pulled negative back on the sheath, made sure that there wasn't any thrombus in there before we took the device in. But yes, the whole time the sheath had been in there without heparin in the patient's system. So before we deployed the valve, pulled negative on the sheath, made sure there was no thrombus, took the device across after waiting about a good minute or so after heparin was given. Literally right after we deploy this valve, we see this, and then it became the debate of what do we do? How do we get that out? So there's a clear thrombus that's attached, and it looks like it's plopping through the valve into the ascending aorta. Any thoughts on what anyone would do?
Send home with it. On board and send home with it.
So after much debate, we truly decided to just take our chances with it. We gave him high-dose heparin. We kept him in-house until his Coumadin was therapeutic, between 2.5 to 3.5 range. We sent him home, and he came back a month and a half later, and his valve is working beautifully well. There's no thrombus that I see, so you can see that's the before, immediately after procedure, and this is a month and a half of him just being on Coumadin and heparin and anticoagulating. He did not have a stroke. There was no ischemic bowel. There was no peripheral ischemia. I'd like to think that it just magically disappeared. So in pre and post, the echo pre showed a severe gradient, and then his gradient at a month and a half was less than 10. So take-home points from this one is that confirmed with the anesthesiologist that heparin was actually given. Wait until the ACT before even inserting the valve into the body, and then sometimes just leaving things alone is the right option and not try to be too heroic trying to suck that clot out and creating more problems for yourselves.
Checklist, that's what eliminates this. People assume other people have done things. We have 2 checklists, one's when the sheaths are in and one's before you're ready to put your balloon in. You can't have more than 5 items on each checklist. It'll be short and sweet. But on the first one, heparin and ACT is one of them. Make a checklist for your side. That's the reason pilots read a checklist before they take off a
No, I agree with you. So the second case, which was actually a great save, it's pretty straightforward. And the 90-year-old lady, critical aortic valve stenosis, symptomatic, coming in. STS score kind of falls in the intermediate risk. She's 90, she's frail. Intermediate risk, we decided to proceed with TAVR for her. Her echo parameters are consistent with more critical aortic valve stenosis. She has non-obstructive coronary disease, maybe intermediate lesion in her mid-LAD. Again, the long and short axis showing that it is a tri-leaflet valve, even though here it kind of gives you the illusion that it probably isn't. So CTA measurements for her, her mean diameter was, probably 20.5 to close to maybe 21. Her coronary heights, her right coronary height was plenty high, it was 13.4, her left was 9.1. Then we looked at the left leaflet itself, it didn't seem extremely larger compared to the other, and there wasn't, most of the calcium seemed to be more on the right coronary leaflet and not so much on the left and the non. We had our TE measurements as well, just to confirm we got our implant angle. There was a debate between putting a 20 and a 23, so we decided to take a 20 balloon and balloon size it. I also put the 20 in just to kind of see how that leaflet behaved in terms of the left main height and how the calcium behaved. And there were some telling signs that probably at this point should have made us think, just go ahead and protect that left main. But we had everything in the room and we just were silly and decided to proceed with deploying the valve. And taking our chances with it. So as soon as we deploy it, she is hypotensive, and then her blood pressure actually surprisingly recovers, and then we saw that flow, sorry. You see that sluggish flow in the left system. We just made sure that there wasn't any significant MR and no significant AI, no pericardial effusion. You can see the short axis view of the LV before the TAVR, and then after you can see the whole lateral wall now being hypokinetic. So I just decided to take a selective angiogram, so I put a catheter, XB35 catheter into the left main and took selective angiogram. You do see flow. I haven't done anything at this point. You're seeing TIMI3 flow in the coronary system. And then on this view, you can see the calcium coming up. There's definitely involvement. You see the calcium obstructing part of the left main is not obstructing it completely. What I didn't capture is then I decided to take a quick picture of the right coronary as well, and I took a JR4 catheter, and when we took the initial injection under fluoroscopy, there was a large filling defect in the mid-RCA. And that's what prompted me to put that wire down, and the moment I put the wire down and took an angiogram, that defect was gone. I wanted to make sure it didn't embolize anywhere distally, and it didn't. As you can see, there's good myocardial blushing. I don't see it anywhere in the PDA or PL. So I took that left catheter out, then decided to proceed with stenting that left main because I didn't want to leave that calcium obstructing. So we took a 4-5 stent, deployed it, and then post-dilated with a 5-0 balloon, and then got good flow in the coronary system, in our left coronary system with no residual defect really, and then just took another final selective angio just to make sure there was flow in both coronaries. And then again, this is the echo on the right that showed you right after we deployed the valve with the lateral wall being hypokinetic, and then the one on the other side is after we've deployed the stent to show that that LV did recover. And her gradient was, well, I saw her, she's 8 months out from her TAVR, and she just followed up with me last month, and she's been doing well, and actually she's out dancing. And takeaway points for this is that coronary obstruction, even though it's rare, it's life-threatening. And when you have coronary heights less than 10, you have long native leaflets with heavy calcium. If you have a small sinus of Valsalva, or as Dr. Ricciardi just pointed out with the last case, when you have valve-in-valve, especially with mitral flow trifecta that have leaflets on the outside, these all increase your risk of coronary obstruction. So it's important to do a careful assessment and look at your images and have a plan in play, whether you decide to protect the left main or do a basilica or decide not to even just proceed with TAVR. So thank you.
If you can stay here for a second. I have a quick question. I think on your first angiogram, when the balloon was inflated, we could not see the ostium of the left main clearly. I think it was more on the irregular view think probably that would have given you a better clue. I think the left vein was occluded then. Right.
On the second case with the balloon.
On the first, yeah, on the second case, actually.
I just asked Danny, I mean, how many, have you done basilica and native valves?
Yeah, this is exactly what I wanted to say. We started by thinking that we tear leaflets of the R cases, of stateless valves that are prone for coronary obstruction. And then came patients with bovine pericardial stenotic leaflets, and we did it in succeed. And then came patients with native AS, and we did it and it succeeded. And it seems to be like in recent months there is a significant growth, especially in native AS TAVR procedures coming from Basilica. In treat cases at risk for coronary obstruction. The risk for coronary obstruction in native AS conventional TAVR procedures is about 10th the risk involving valve procedures. It's much less than 1%, but we have many more conventional TAVR procedures than valve. Eventually, I think that it would be around 50-50 valve native TAVR cases coming forward.
How many native basilicas have you had? 15?
Around
Are they mainly bicuspid valves that are mainly the circularizing, or are they cases like
No,
this?
only one of them was a bicuspid that was the intention. It was
Did you-
conventional native AS, usually in patients with very small anatomy, very small iliofemoral, small sinuses, that we needed even to do transcameral to bring the device there.
Did you do any for just bulky leaflets, not because of coronary height, but just because the leaflets were very tall?
There is only one case that the distance was quite okay, but the leaflets looked like they were rheumatic disease or something, very bulky, and usually it's not. That was the
And you were able to cut across the bulky leaflet just fine?
yes. Yes. Sometimes it takes more time.
Yeah.
Do you put the sentinel up
It's
first
amazing
before you do that?
somebody's been cutting these valves out for 35 years, that, that you can actually cut across that with anything less than a chainsaw. And the great thing about being older is I've been wrong so many times in my life that you know the line. But, we go in and cut these valves out and take a pair of heavy scissors, to cut across this thing. But I think some of the work Danny's doing, it continues to amaze.